Well, I guess we'll begin to get started with the final plenary of the day on health information technology and what's going on today and hopefully in the future. What's the status of privacy and the right to control personal information in the healthcare sector? So specifically, this is computers, freedom, and privacy. So we are going to be talking about privacy as it relates to health technology, but you're going to find out this is an amazing panel of experts that have a lot to tell you about what's going on and what may go on. And so part of why we're here is the reality is, and I don't know if you know this, is anybody here from healthcare sector? No, okay. Computer scientists? Okay. Academics? Students? Who are you all? Okay. All right. Okay. Well, okay, then it's going to be a mystery, so we'll have great questions. Okay, but so I'm going to start with a couple of basics. The federal government in the stimulus bill is going to push $27 billion at least into building out a massive health technology system for electronic health records. Do you know that both administrations, this and the previous, have agreed that every American will have an electronic health record by 2014. Did you guys know that? Yeah, okay. That's kind of a big commitment. And so there's all of this money pouring into health information technology. It's really a gold rush because the industry's annual revenues, I think this is right, Mike and Mark, you can correct me, the industry has been getting about $9 billion a year in revenue. So think about how many billions the stimulus is pumping into this sector, and it's a gold rush. So people want to build things, and they want to build them fast. What we're going to get is systems for biosurveillance, research, and a myriad of other uses that people don't know about yet, because every EHR will be backdoor data mined. So this is going to be our structure. We're going to do that. We're going to try to keep this lively and interesting so that you have a chance to ask questions too. I'm going to ask each one of the panelists to talk 1 or 2 sentences. What's their experience, their perspective and motivation, and one concern that they have that's really important. And then we're going to move to some specific questions. And, I guess I'll start for those of you that don't know me, which looks to me like it's everybody here. I'm a physician, I'm a psychiatrist, and a psychoanalyst. I've been in practice over 35 years, and I learned about privacy from my patients because when I first opened my doors in the late 1970s, people said, "Hey, if I pay you cash, will you keep my records private?" That's the paper age. I'm a Freudian psychoanalyst, and it turns out the very best conditions for people to feel free to share their deepest fears and the most embarrassing things that bother them are conditions of total privacy. No secretaries, no answering services, take my own calls, make my own appointments, write my own bills, the whole thing. It's completely private. So fast forward to the HIPAA Privacy Act and the psychoanalysts. There's only 3,000 of them in the country. We're following this, and we saw that the HIPAA privacy rule was changed. So my motivation is really I started patient privacy rights really to inform and educate the public and decision makers, because I'm afraid that if we lose our rights to control personal information in healthcare, we won't acquire them in other areas online and in the internet world. And my big concern is if we don't build these systems right, people won't see doctors. They won't see doctors because they're afraid to get treatment if it's going to hurt them. So let me turn to Stephanie. You want to talk a little bit about your experience, what you care about?
Thanks, Deborah. Stephanie Perrin. I've spent most of my career working in the Canadian federal government, mostly in the area of privacy. I'm not here representing them. I have returned to school at a ripe old age, and I'm at the University of Toronto studying in the Faculty of Information, hopefully to get a doctorate. My research is focused on identity And that, of course, is relevant to the healthcare privacy issues because people have a concept of what their identity is and that may not match with what's actually happening with the data that constitutes their identity, particularly in electronic records.
Thank you, Stephanie. Mark, how about you?
Hi, my name is Mark Frisse. I'm a professor at Vanderbilt University in the School of Management and the School of Medicine. I have a background in internal medicine and in computer science and in management. I've worked in the private sector in universities. My salient background here, I guess, is I led a initiative in Memphis, Tennessee for about 6 years that actually created an environment where information could be shared among all the hospitals, among consenting patients, and worked pretty hard on that and learned a lot.
Dave, you want to try to explain yourself, your experience? What moves you? Why? What you care about?
I'll describe myself, but explanations are hopeless. So my name is Dave DeBroncard. I'm known on the internet as e-patient Dave. A few years ago, after surviving cancer, I stumbled into the e-patient movement, which was started by a doctor who died in 2006, where the E stands for Empowered, Engaged, Equipped, Enabled. And the group has since incorporated as the Society for Participatory Medicine. It's in my last year as its co-chair, and we are about patients being more actively involved in their care and in collaboration with their physicians. Obviously, access to our medical records is an essential part of that. And how I stumbled from Nashua, New Hampshire to being at a policy meeting in Washington is that 2 years ago, I wrote a blog post. I tried to move my personal health data out of my hospital's record into Google Health, and what came across was crap, total garbage. And it turns out that a major reason for it was that it was not my claims data. It was not my medical record, it was my insurance claims data. And anybody who's looked at that data knows that it bears no relation to reality. So
that'll be probably new for this audience, yeah.
A surprising number of people, including people making IT policy decisions, didn't seem to know that. So anyway, I'm just a guy who worked in high tech all his life and then got interested in healthcare, and so now I'm doing what I can to try to put us more in charge of our data. That includes you and your mother.
Thank you. Mike.
Yeah, hi, I'm Michael Stearns. I'm a president and CEO of an EHR company called e-MDs, and I'm a physician by training, a neurologist originally. So I had about 15 years clinical experience, and then I've been working in the HIT industry for about 15 years. In our EHR, we responded to customers' requests that we block certain information. So we have tools in there that will either eliminate or put a black box over sensitive private information. So I'm very interested in the value of HIT and how it can help healthcare. But I view privacy as not only very important as a fundamental construct, as a right that everyone should have in this society, but also it's a sleeping giant that could really disable and impair HIT. It is one topic that everyone can relate to in HIT, and it gets people very excited. If you've read some of the articles about privacy, there's nothing that's more emotional in the HIT world than privacy discussion. So I think we have to really be aware of this and not go down the road like they did in England, where they sort of were a little cavalier about privacy and they got burned big time. So we need to kind of stay on top of this, educate patients as to what the value is, and also make them feel secure that their information will be safe. Thank you.
Devin.
Thanks. I'm Devin McGraw. I'm the director of the Health Privacy Project at the Center for Democracy and Technology, or CDT, nonprofit public education and advocacy organization, mostly here in DC. We have a little office in San Francisco. My experience, so I actually only became a privacy advocate about 3 years ago, and before that, I was a healthcare advocate. Worked for the National Partnership for Women and Families, which is another consumer organization that pushes for higher healthcare quality, not just better access to health insurance, but also getting more out of the more quality for the amount of money that we pay. And realized in doing work to promote health IT as an enabler really to the flow of data that is essential to improving our healthcare system, that you're not going to have any of that all of which is as important to patients as privacy. You're not going to have it, though, if you don't build the right privacy and security protections in and hold people accountable for complying with them, which we don't do such a hot job of. So I would say that my overall perspective is that we sort of have two aims here, which make the privacy and security challenges actually pretty intense, because we actually are trying to promote some data flow while also protecting it. And the one area of concern that keeps coming back to me among the myriad of things that we could talk about on this panel is a lack of sort of consistent accountability and clear guidance from regulators. And I think it hurts us in many ways.
Thank you. Carl.
Excuse me. I'm Carl Gunter. I'm a professor at the University of Illinois. My early background in the subject was in software engineering and analysis of programming languages. And I got into security and privacy areas because I had a number of projects I was working on where I found that the barrier to those projects were the security and privacy concerns. So over time, I got to where I mainly just worked on security and privacy concerns, the interest being that if there's something that society you would like to do for virtuous reasons, then it's a pity to see it held up because you can't conquer the security and privacy problems with those things. And so that my interest is primarily as a technologist, which is as people decide they want to be able to do something with the technology, that we should not be held back because of threats from parties that might violate the security of the system, or because we can't handle the privacy restrictions that will be needed to make the system satisfy people's needs for privacy. So I've gotten an opportunity to instantiate this in the healthcare area. I'm the lead on the ONC-sponsored Strategic Healthcare Advanced Research Projects for Security, which is a consortium of 12 American universities consisting of some of the leading computer science departments and medical schools, and we are working together to try to contribute technologies that can help defeat some of the barriers that prevent us from moving ahead with things we would like to do, but where the concerns about these risks are stopping it.
Thank you. Well, why don't we start with talking to the audience about what you think is different about health information from other information. How different is it from banking and legal information? How different is it? How differently do people feel about this information? What do you think about the differences? And we have two physicians and a patient. So let me start by asking Dave. What do you think about the privacy of your health information? How do you have different feelings about that compared to financial or other information, and how it's handled and held?
Well, it's funny because, as I said, I've worked with information all through my career. I only got interested in the healthcare aspect of it inadvertently, after when the doctor said you're almost dead, and all
That'll
of a sudden
get your attention,
I really
yeah.
cared, But as it happens, people tell me I'm somewhat unusual because I came to advocating for patients without having been injured first. Okay, a lot of people get into advocacy when they were harmed. Mm-hmm. I was saved by great physicians, and then afterwards, while thinking, I'd like to help improve healthcare, I stumbled into this issue of poorly managed data. As I think about data workflows, okay, I've done an awful lot of marketing. I've automated typesetting systems, all different kinds of things. What stands out like a sore thumb to me about health data is it's the only data I've encountered, with the possible exception of airline information, where good data, well managed, being in the right place at the right time can save lives or cost lives if it's not there. Okay, and that kind of changes everything. After that episode I mentioned 2 years ago, the blog post I wrote about that crappy data ended up on the front page of the Boston Globe, much to my surprise. I had no idea there was discussion going on in Washington about using claims data to populate our medical records. Which
pretty crazy.
Crazy stuff. Well, so and at the first meeting I came to at CDT, I listened to 30 people talking about these deep, deep things about HIPAA violations and disclosures and all kinds of things I didn't comprehend. And at the end of the day, I was the last one to speak. And all I could say was, one of the most essential human rights has to be the right of a desperate person to try to save themselves. You know,
Absolutely.
and whatever we do to keep the data safe, secure, protected, safe from violations and abuse, let's not interfere with the ability of a desperate person to pick up their data and go somewhere else to get a better treatment.
Absolutely. That's actually one of the ironies of data flows in healthcare. The data flows in many directions that we would not know about or not see, and yet when we need it for life-saving things, it's not there either. Mark, what are your thoughts?
I have one more little thing to toss in, but go ahead.
No, go ahead.
Well,
Well,
it's your event.
Okay.
So.
Okay. Mark?
I'd so much rather listen to what Dave says. I saw my last patient professionally in 1999, before networks were a big thing, where you were lucky if even people who were authorized to access data in electronic forms could get access to it, much less anyone else. And we lived in a paper world, and we knew there were threats, but trained as a physician, you're just so idealistic that wanting to take care of people, it never occurs to you that there's a downside to sharing information. You don't think a lot about the financial implications. Of course, you were unaware of this highly connected world. I remain convinced, after having been in the essentially health insurance industry and as a consultant in IT and doing large-scale regional projects, that overall the vast majority of people believe when they're caring for patients that they want to do you well, and that it's both in the patient and the individual's interest of the team providing care, that the more information is the better, and that Hippocratic oath that Deb talks about and upholds in her everyday life is very much applicable. But what I guess I didn't understand until I look back on it is the enormous ways in which your data are used every day. In our ability to exchange data among people in Memphis, Tennessee, patients were allowed to say, I don't want to participate in that. The irony was, I'm afraid that many of them probably thought that by saying no to that, that somehow their information was remained just as protected in that sense as it is in Dr. Peel's office. Nothing could be further from the case. There are a wide range of people with real reasons to access medical data, including fiduciary responsibility, public health, many other things. And so overall, I don't think most of us really quite understand where our information goes today and why. And there are a lot of good reasons it goes many places it does, but we need to elevate that discourse and use this electronic world, I think, to bring it forward so that we can explain it all in terms we understand and see the pluses and minuses.
Thank you. Stephanie, you want to tell us a little bit about how Canada treats health information? What are your thoughts about the differences and protections it may need? And what do you know about the data flows in Canada?
I mean, at the risk of being the odd man out in the panel and starting controversy when everyone's having a nap.
We don't want napping. Yeah.
I'm not convinced that health data needs to be treated any differently than any other personal information. And the fact that there isn't overarching data protection legislation in the United States kind of sets an unusual stage for the health data. It's special. That doesn't happen in Europe, where there's, they do make the distinction of sensitive data, but I would argue that, your political views can sometimes cause you as much, possibly not life and death in this country, but they can cause you harm, and various other types of data can cause you harm, and usually those are categorized as sensitive data. In Canada, we did pass data protection for the private sector. Almost by accident, it covered health data that was encompassed by commercial activity, which covers a lot of health data. The provinces have the jurisdiction for health coverage in the universal health care system. They manage it, and therefore the data is also managed provincially. And since the federal bill passed in 2000, many of the provinces have passed particular sectoral legislation to cover the health data. I'm not convinced myself that that was a gain, because once again, the data is so hard to disentangle health data transaction data, financial data, geographic data, particularly when you start getting into research and epidemiology and all these other uses that are intricately involved in this tangle that we have. I would just like to make an apologies to anyone who was here yesterday. I'm going to keep hammering this point home. When we passed that legislation, and it was tabled in 1998, I believe, we didn't have a data map for how health data traveled, who got it, where it went, and that's kind of basic. If you don't know where the data is, you can't really figure out particularly what technology you need to manage it and what systems you need.
Do you know now?
No. I've been asking for a data map now because I'm interested in certain ends of this puzzle from what I'm doing now. And apparently we don't have a better data map now. There may be data maps buried within organizations as they've met their legal requirements. But from the patient's point of view, from the society's point of view, we don't have that map. And if I can make one more point.
Sure.
I had the pleasure last night, there was an Epic Awards dinner, and I got lucky. I was sitting beside Claire Nader, and I was telling her about the healthcare data day that we had. And, raised the issue of whether it was, data about the individual or data about the consumer or patient. And she said, it's about the citizen. And, of course, if you're associated with public citizen, you probably feel passionately that it's always about the citizen. Mm-hmm. But I think it's an important point that I hadn't thought about, particularly easy when you have universal health care. Everybody's a patient sometime. You may get lucky and not be a patient for 40 years, but sooner or later you're a patient. So first and foremost, you're a citizen and you have rights and you're participating in a democracy where protection of personal information enables your autonomy. This is it. This is kind of fundamental. So I thought I'd just ventilate that new idea, which I hadn't.
Love it.
You like it?
Yeah.
Good.
And I'm going to call on you some more because I think your ideas coming from such a different legal framework and rights framework are really important here. We're challenged. We don't have the same kind of sense of citizenship here yet. But why don't we move to Mike and e-MDs, because part of what we need everyone to learn about are what are the challenges, and as an electronic health record provider, developer of software, what are the real challenges on the ground with respect to this growing digital healthcare environment for you and for the doctors and patients that you're trying to serve?
For one thing, the information we have to work with is complete rubbish. The information right now, it's all claims data, so doctors can't use it.
Or back to Dave's point, yeah.
We're trying to overcome that, but it does involve privacy issues. Just as an example, when a doctor makes a decision about what code to use, they base it upon financial reasons, getting the patient paid and getting them paid. So a friend of mine's an orthopedic surgeon in South Florida. He said most of his colleagues who do spine surgery would be in jail right now because all their patients are quadriplegic, because that's the code you have to use to get it paid for. So it's just silly, the rubbish you get out. So the challenges are we can't get doctors to even use EHRs in this country. Even now with $18,000 pineapples raining from the sky from the U.S. government, people are still not adopting. So it's a big challenge here with mandation. So now we're into why don't they do that? Well, it's because they consider it cumbersome or it takes them away from medicine, the art of medicine. And now we have to introduce, to protect the patients and protect the providers, we have to introduce privacy as a component. It's another step too far. So one of the biggest challenges right now is educating providers how important it is for privacy, and we're not hearing it on the streets from patients or from providers or from others about privacy. We're hearing it in smaller groups. But as I mentioned earlier, I think it's a sleeping giant. I think patients can become aware their data is being misused, and they're going to erupt. So what I think we need to do now is kind of stay a step ahead of that and create structure so that an educational program so everyone understands what exactly it means. Your data could be compromised, but hopefully it won't be.
Well, let me just break in. Well, first of all, do you all know that physicians and hospitals are getting, this is part of the stimulus money, they're getting large amounts of money to put these records in place? You're all aware of that. Okay. How many of y'all have electronic health records? One person, okay. Yeah, okay, well this is, okay, a couple people. What? Do you know of any type of electronic stuff in your doctor's office? How electronic are there? Some. Okay, some people are having things. Yeah. Yeah.
But I went to the doctor, well, one of these first care places, you stub your toe, you can get it taken care of. They asked for my driver's license like they typically do and my medical ID card. I gave it to them. I didn't realize they had this little scanner.
They made a copy.
Oh, believe me, they did not keep my driver's license. I stopped them right there and I told them to get rid of it. And I let them know about the Driver's License Privacy Protection Act and whatever else I could think of to scare them half to death to get rid of my driver's license. But anyway, no, it did. It did. No, but the point was they had gotten this new technology and didn't think anything about, the insurance card I expected, my driver's license I didn't. And so, yeah, I think we have them whether we know it or not. So.
Yeah. Well, back to the challenges in the growing digital environment. Devin, what are the risks?
So I'm not sure that there's another sector of the economy where we have such a disparity in terms of resources and level of knowledge and expertise on privacy and security issues, dealing with some of the, whether you quibble about whether it's more sensitive than other data, they are dealing with sensitive data. I think we could all agree. You have 1 in 2 physician practices that are going to be adopting electronic medical records.
And they're not technologists.
Sharing data. They are not technologists. They are purchasing a system that has built-in technological functions like audit trails, encryption. They may or may not know how to use them. They may or may not turn them on.
Exactly.
And yet, with the security and privacy of the whole system is only as good as its weakest link, right? And we got weak links all over the place. Then you contrast that with, Kaiser, major healthcare system with lots of resources. We, ideally could have some higher expectations on what they can and should do, but it doesn't, the fact that we have such disparity in the level of expertise, the level of understanding, the level of appreciation of the issues, the fact that, when one physician practice misuses data, it creates a breach in the trust potentially for the entire system, or the entire system in that community has an impact on all of the other providers. How do you deal with creating protections that somebody at a practice that small with very little expertise or places to go to for advice, how do you build a system that works for them and deals also with the big institutions is an enormous challenge. I don't think we figured it out.
Excellent questions. Yeah. So we have little tiny 2 physician practices, and we have giant corporations, Kaiser, Geisinger. Who are some of the others? Intermountain,
Mayo, Cleveland,
yeah, there are all kinds of them that have
plans.
Yeah, I've spoken in Mayo. They have an IT force working on their records of 1,500 people, 1,500 senior technology people at Mayo, and then you have solo doctors like me who can try to figure out how to encrypt my laptop. I mean, these are real serious disparities, and. Mark, can you talk a little bit about what you think is going on that might mitigate some of these risks? How is this going to happen? I'd just like to add one other thing for this audience. I was stunned when I learned that most hospitals don't have one electronic health record system. How many are you all aware of this? Okay. EHR, I pictured one. No. Hospitals typically have up to 300 different kinds of software moving different pieces of health information around. And they all have to work together. They all have separate contracts, and some of the contracts enable those vendors to use and disclose your data. And so these are incredibly, to me that was really a wake-up call, incredibly complex systems compared to how we might think of, say, the systems that run in PNC Bank. So Mark, what can you tell us about anything that might mitigate these risks? We've got solo practitioners, we've got giant systems. Do we have enough technologists and computer scientists to even deal with all these problems?
I think collectively the answer is probably yes. And having a psychologist myself who I found out keeps my trivial problems on Microsoft Word documents and an unencrypted desktop computer, I found the need for education to be very important. So clearly mitigation step number 1 is to be aware. Mitigation step number 2, if you look at the breaches overall, it's that so much of our information is not encrypted. I mean, think of all of you with laptops right now. If that were taken away and it's not encrypted, what would it do for you? Then imagine if you had everything with your passwords, your medical history on that. The heterogeneity that has been mentioned is huge. The schizophrenia in our healthcare system that we have used medical claims to codes that are optimized to get money to describe a clinical state is just so fundamentally misleading. Dave mentioned it. Devin's mentioned others are. I call it Mike. I'd say it's like talking about a claims-based health information. It's like saying a coal-fired jet turbine. It just doesn't make any sense to think about those two things in the same sentence. And I think the other thing, though, is to, in addition to the public education, is to think very, very hard about what is important. Pay a lot of attention to what are the important steps. With my very mixed feelings about High-Tech Act being in the context of an economic stimulus where you try to throw money into a problem as quickly as possible in a Keynesian way, I sometimes think if only we could slow down, if only we could have more debates like this to figure out what are the really important things and go after those. Right now we're just overwhelmed, as are practicing physicians, with so many changes, so many regulatory things, so much complexity in the health plans and the like, that it's very difficult to keep your eye on the ball for any specific problem.
Thank you.
I used to be Director of Privacy for Cancer Care Ontario, which is the agency that funds and directs the treatment of cancer in Ontario. And I used to work for the Information and Privacy Commission of Ontario. I preface that just so that I can, unfortunately, add a few more complexities to the issue. First, they're not all patients. When I do work, when my clients are in mental health, they don't want to be called patients, they want to be called consumers. And they and their doctors are very sensitive to privacy and very clear on that. But when I talk with community health doctors or public health doctors, they have a different sense of responsibility, a different understanding of privacy and security. So the range of opinions on privacy that we see on some of these panels, those that were here with the yay and boos and the right and the left, are replicated in the medical community. And thinking about the electronic health record and think, oh, that person has got a single record that the docs are going to access. Not true. The people go to different doctors for different reasons, and they don't necessarily want them talking together. So the idea of in Canada, we don't have the same insurance issues you do, but we also have the stigmatization issues and others. So you have to add those dimensions to your analysis as well. So to a point Stephanie made the other day, change is hard.
Change is hard. Yeah. Well, I have one other comment to add to this this thing about using claims data, and then I'm gonna ask you to respond, Stephanie. The president of the TMA, Homer Layden, said, "You can no more tell about the quality of food from the bill you get at a restaurant than you can tell about the quality of the medical care from the claims data." So, that kind of puts it in perspective. What does a bill have to do with the quality? So, Stephanie.
I'd just like to make the point that I think it's really important that we figure out what the frame is for the problem we're discussing. And as we talked about when we were getting coffee, HIPAA's about portability. It's not about privacy. And
That's right.
As a longtime privacy advocate, privacy is not about privacy per se. It's about autonomy and enabling people and providing the decent standard of living that enables, democratic life and reasonable transparency and all this. So it's a broader frame that you want for this. You want privacy for patients so they'll get care. That's part of a broader social goal. I'm afraid that a lot of what we do, and I don't mean to pick on the United States,
Please.
We do exactly the same thing up home. We throw money at a problem. It's for putting informatics into records to cut costs in billing or to categorize better. I commend the book Sorting Things Out by Bowker and Starr to anybody who's interested in the categorization of people by diseases. It's a really interesting take on this. And from the identity perspective, I'm concerned about how we peg people in the system. The reason we're even pegging people in the system is the frame we've set up. It's kind of, can I use the word patriarchal? In Canada, we didn't get a Supreme Court case that established that a patient had a right to see her record until 92. And to me, that's, I know I see a young crowd in front of me, but that's recent history as far as I'm concerned. And so if the frame is that you're looking after the patients, that these are not citizens that are entitled to services and privileges and rights, then your frames aren't going to ever meet, and so your goals aren't going to.
Mm-hmm. Well, Devin, I'm sure you all don't necessarily know what Devin does, but she is the chair of the federal advisory committee called the National Health Information Policy Committee. And so under her leadership and guidance, the government, along with members of the public and industry, are pumping out regulations that are going to specify what kind of things we can get. What can you tell us about what to expect right now? What can you tell us about our ability to protect our information,
Sure.
segment sensitive data? What's the framework here now?
Well, you did promote me. I just had the privacy and security.
Oh, I'm
working
sorry.
group, not the
Okay.
whole. No, you don't
the
have
key
to
piece.
apologize.
The key
although
piece.
It occurs to me that I've suddenly taken on this enormous responsibility. I think so. This is a multi-stakeholder group. So you have sort of consumer voices around the table, but you also have physician voices around the table. You have vendor voices around the table, people with security expertise. And so it's a little bit of a, we have sort of tried to push for a fair information, practice-based framework of privacy protections, but also technology components that really sits on top of what HIPAA is the baseline in the law, but doesn't answer many of the more significant questions that arise with these new infrastructures that we're building. So trying to create sort of a set of best practices or policies. Again, we're just a recommending body, so what we say goes up to the Office of the National Coordinator for Health IT, which is an agency that sits within the Federal Department of Health and Human Services. And so
and you're recommending?
And we have recommended, again, that, so we've tried to take into account the fact that the data is going to flow to a lot of intermediary entities, middlemen, vendors, health data aggregators, and finding a way to hold them more responsible for how they handle data, something beyond a mere business associate agreement, asking them to comply with fair information practices and be strictly limited.
Do we know how many intermediaries there are?
No, I don't think. I mean, so Stephanie's point about the lack of a data map, I mean, there's really very little transparency about these data flows. There was actually some regulations in California that proposed requiring some grant applicants to actually report the number of contracted entities that they were sharing data with, and only 2 entities applied for funding under that framework. And it'll be very interesting to see what gets revealed in terms of the amount of data that gets shared. But even if you think about, without knowing what that map looks like, is it possible for you to say, at a minimum, if you're sending data out the door, it needs to be under some very clear guidelines that you at least have somebody contractually obligated for, but ideally there's some accountability that extends beyond the contract. And thinking about how you create a framework of accountability in an environment where the regulators are only going to be willing to go so far. We know that under HIPAA is only so far that the folks will go, and trying to negotiate that with a set of providers, vendors, and others at the table who, have broader information sharing interests at stake. it's been a challenge. It's done in a public process, but I'm not sure that enough people are paying attention, to be quite honest.
So can we know where our data goes? What about the new audit trails? And then I want to ask Carl about this diverse system and whether
on audit trails.
computer systems can.
Well, I do want to ask,
them.
actually, this is a question.
Sure.
In 1997, there was an NRC report that gave data maps. And then in congressional testimony, LaTanya Sweeney gave data maps for this. And I was wondering why we keep asking for data maps when there are publications that have that kind of thing.
Well,
but aren't there new entities? What do you think?
Yeah, I mean, I think there. Well, I think I've seen that data map.
The 1997 one obviously has changed.
You don't think it's changed? Yeah.
I'm not sure we could use the 1997 one. I mean, I'm not. I'm trying to think if I've seen it before. I'm not sure it is as specific as one would want it to be. It has sort of your health data is shared with pharmacies, pharmacy benefit managers, then data miners take it, they share it with employers, they share it with health plans, so you have sort of categories of entities. But that doesn't, I sort of want to...
scary and overwhelming.
It is scary and overwhelming, and it's not that, you almost want a GPS, little mapper on a data point, so you can actually really follow it.
That's exactly what you want. I think that's what I'm talking about. I want to know where my data is. I mean, Fred Kate in that book.
What do you think of LaTanya's report, though?
I think it's possibly throwing too much money at the wrong problem.
Well, let's explain a little bit more. Can you say a little bit more about LaTanya's report?
Yeah, so LaTanya had a report she gave to the Congress. She came and gave a presentation of it.
Everybody knows LaTanya Sweeney, right?
It has a complicated map of where the data flows in the healthcare system, similar to this 1997 NRC report. And I think this is an important question, is like, where does the data go? Right. So if you're going to try to tack that down and look at the security problems, then the flows would be one of the first things you'd look at.
But is the government actually trying to do that, trying to track this down?
Well,
Devin's shaking her head.
She was supported by the HIT Policy Committee from Owen.
Yeah, I know, but I'm not aware of any dedicated effort to map data.
And the accounting of disclosures is not required of all of these participants that hold health data. Is that right?
No. So accounting of disclosures is a HIPAA requirement. So already you're talking about a limited set of healthcare entities that have to comply with it anyway, right? So, and it just requires you to, they've got some new rules on the table that would allow people to see, essentially an audit trail of access to the record if they wanted it, and then some limited number of what I'll call extraordinary disclosures out of your health record, like a disclosure to law enforcement that you might want to know about, but you only get it if you ask for it. Very few people ever do. And it's not going to be a very successful data map because it's only going to show you point A to point B.
The first disclosure from an EHR from a hospital or a doctor, but none of the onward disclosures.
Right, and then I think the other thing to keep in mind is that these rules about such as accounting for disclosures apply to what's referred to as protected health information. So it's identifiable data. Once data meets de-identification standards under HIPAA, it completely falls out of regulatory oversight. And so where it flows from there, so I would say, if LaTanya's map was an attempt to account for where even the de-identified data goes, I guess I would ask her how she could possibly know, because nobody has to account for it in any way, shape, or form, or be held accountable for it. So it's almost impossible to know where it goes.
Let me ask a computer.
Like a piece of dust.
Let me ask a computer scientist, Carl. Would there be any way to find out? Is there any way using technology to find out where all the data goes?
No, not really.
No.
The data.
Wow, that's discouraging.
That's nothing to laugh at. That's the internet. I'm sorry. Let's be real here.
So copying can't really be traced. Although you could, of course, ask the organizations, and I think that's what LaTanya did, and you got some information that way. But a lot of the information, if they had a flow, they might not admit to it. So.
So, Stephanie, in Canada, how much does Canada literally and strongly apply FIPS, one use, no onward transfer of data without a new consent?
Well, funny you should ask that question, because I've been sitting here ruminating about a case that really kind of kicked the hornet's nest over. Back in about 2005, the British Columbia Data Protection Commissioner received a complaint. There was a bid to cut costs in the province of British Columbia in the processing of health claims, health data. And so they were going to outsource this to a company called Maximus. And of course, Maximus was going to send it south of the border to the United States, and the complaint was that it would thus be accessible under the Patriot Act. Some of us were kind of, okay, that's not all it's susceptible to once it goes south of the border. But this, the BC Commissioner opened a call for comments. I recommend it to you if you're interested. He got hundreds of comments, I believe. I can't remember the exact number, from all kinds of different parties. And this prompted a wave of closer examination on the part of government entities as to, gee, where's our data going? After this kerfuffle. So it went on quite some time. The data all used to be up on his website. I hope it's still there, because it was an interesting example of sort of the case that really got things going. And Maximus came out with a lot of very stringent protections and huge fines if anything went wrong. It was kind of the first case of a company really having to meet high standards in order to undertake this processing. And this was at a time when we were getting these stories. I remember when some of the Indian transcribers offshore were, remember that, threatening to expose all the records if they didn't get a decent rate of pay. So it was kind of an epiphany in terms of where's my medical data really going. So I would say our act cleaned up a bit after that, but I think it's a hard problem.
It's a hard problem. Back to the hard problems. Carl.
Well, Deb, I want to comment that there were efforts this last year, to discuss the possibility of putting labels on the shared health data in the form of a metadata tag that describes privacy rules for those things. And once this is set up, one could, for example, legislate something like, do not remove this label as the data moves through the system. So you'd have a mechanism for tracking
do not
the data.
remove the label? You mean people can remove
suddenly
labels?
I have a mattress tag image in my head.
Yeah, that's a picture that comes to mind, isn't it?
So that's right, and that's actually why they do that with the mattress tags. It's accepted by the end consumer, and that way, as the thing moves through the system, you can tell some property of it from that. Now, of course, with data like this, computer data, you can make a copy out of it and take it away from its tag. There's nothing technically preventing you, but at least some large entities will respect these rules because of fear of fines or just expected business behavior. And so once we do actually go to a system like that, we might have a better chance of doing this tracking.
Michael.
Yeah, well, there's no federal mandate or requirement that, or no law against re-identifying data that I'm aware of that's been de-identified. But there is in Texas, actually.
Yes,
so we
that's
work
right.
with Texas legislators. And of course, you can be shot in Texas if you re-identify de-identified data. Just kidding. But,
but who would know?
We actually built it was a good starting point for us to work with legislators to help, work. And it actually extends beyond Texas borders. So there's case law where the AG has gone after even other countries if they violate that. Now,
other countries?
It doesn't really protect the data necessarily, but it does give, at least for people that think they can own the data and re-identify it for some reason. We heard yesterday that legal groups will re-identify data to the point of zip codes for patients who took a certain medication and then reach out to that area to try to identify patients in that area, Mr. Profile, so they can market to them for lawsuits.
Well, actually, I've heard that some of the big prescription data miners actually sell to trial lawyers just for that purpose. Because they want to.
That's basically what So, I mean, in theory, maybe we can,
right?
It would block that to a degree, so.
Yeah. Well, what are the visions that we have? Carl, you started to talk about a vision for one type of system that would provide some greater protections, and maybe you want to say a little bit more about that. Maybe Mark has some ideas about what kind of a system we could theoretically have that might work, or what are the limits? What can we do? What are the limits?
Yeah, I'm a technologist, and so I look at this subject and ask, why are you not up to date in certain ways. I mean, and also what's different in this space. I had the opportunity to participate in some of the Institute of Medicine's Learning Healthcare System workshops, and few fields could benefit more from computer use than this field. I mean, so the idea that you could take something and ask, what patients are similar to this, and what was their treatment, and what were the outcomes of that treatment, and have a computerized system tell you that, rather than relying on your personal connections and memories of people that you've met and so on, or the research literature, which might be quite limited. You have an enormous capability in this space, and it would be a terrible, terrible pity if we can't move ahead with some of these things that will improve care and reduce costs because we can't cope with the security and privacy limitations. Some of these areas are low-hanging fruit. For example, the data compromise data from the healthcare area, someone was saying on a panel yesterday, something like 80% of those were attributable to physical loss of media. 80%, so that just, the application of basic, well-known, inexpensive techniques could address those problems. And so that, that we would be fearful and that we wouldn't take advantage of some of these opportunities that are ahead of us for a much more advanced type of medical system, more advanced than has ever been seen before, would be a very sorry outcome.
There's, I think everybody here in particular understands what data analytics could do for research,
And so one thing that I always, my personal thing for me was, why is it that when I go to a physician, I can't see every record about me that I say that they should be able to get, instantly?
You should.
As part of my care, right? And so we have now so many impediments to getting the data to move between the different parties that have the data. And there's some interesting security challenges and privacy challenges making it happen, but it seems like a very fundamental capability that I think is within, what we could do with the technology easily if we can conquer these problems.
Well, Mark, what's your understanding of why entities don't want to exchange data?
Well, it boils down to actually two real fundamental things. And sitting here and with the notion of citizen, which I would urge people to return to. We sit in this room where we talk about justice and citizens all the time. What does it mean? It's a really cool setting for this. The first of these is really, what does competition mean in healthcare? Michael Porter at Harvard said it very well. He said, competition in healthcare is a good thing, but you ought to compete over the right things. What do we compete over? We compete over basically identifying the healthiest people to put them in our health plans so that we can mitigate our risks, because fundamentally, we as Americans are a bunch of self-serving narcissists who want a lot more than we're willing to pay for. I want everything, but I don't want you to get anything. Face it. So these plans are in the middle. So what is their strategy? Find healthy people, try to identify people who are not. Our employers have this incredible moral hazard where they get tax deductions based on our health care costs. So justifiably, we are concerned about our health because it affects our employment status, because frankly they have a fiduciary responsibility too. So first of all, we probably compete over the wrong things. Providers do too. They're afraid that if they make information about me available to someone else that they will lose a competitive share or whatever. Then the second thing, and I'll leave you with this, is complexity. Just as I think that we're competing over the wrong things, we have developed an analytic system that is so complex that no one understands it. And as Carl would attest, one can model an even more complex system. I mean, and then you'd have what Clay Shirky and Carol Diamond in Health Affairs talked about. You could make our complex system stupider, consistently, really even faster. And the first thing you have to go back to is, why is it so complicated? What are all these things? And I think since we're having more of a scholarly debate here than the pragmatic issues that Devin has to deal with every day and Mike has to deal with, it's good to sit back and think about, what does competition really mean to create better care for us, and what sort of complexity do we really need? For example, if we didn't have computers and all the skills, would our tax system be this crazy? Probably not, because we couldn't enforce it. So, competition, complexity.
Competition, complexity.
I wanted to follow up on the theme here a bit, because I'm starting to wonder if maybe part of the problem is we're trying to run before we've learned how to walk.
Yes.
From what I've read, some of the most important medical advances over the last few years have been incredibly simple things. You know, for example, the use of checklists in operating rooms. You know, actually making people consistently wash their hands.
Which they don't.
But they're doing it more now. The other day, I read in the paper about how iPads are transforming the cockpits of a particular airline. How are they doing that? They're sticking their airline flight manuals on them, all right? And that's literally all it is. They're just taking all this paper, which they used to have to lug around, and they're sticking them on iPads. The functionality, in principle, is actually very simple and straightforward, and yet this is being, you know, hailed as a really big deal. So is part of the problem that we're just too ambitious right now? We're trying to do this big, humongous, all-encompassing revamp of how health information moves and gets used. You know, maybe we'd be better off trying to do just, you know, some much smaller, simpler things before we start trying to do the big ones.
Who'd like to respond? Dave. 1 second, we'll give Dave.
Absolutely correct. It's consistent with what I said about how backwards so much of the healthcare industry is. Imagine if the airline mechanics on that airline were blocked one way or another from seeing the service records of that airplane. Okay, because that is very often the reality. You know, in quality movements in other industries, it's axiomatic that the information needed to work on something should be at the point where the work is done, not in a centralized manufacturing control facility.
Amen.
But the reality, and there's a great new book that just came out, Personal Health Records, a Clinician's Guide, that describes this just in like 100 pages brilliantly. The reality is that all this data in all those 300 systems that Dr. Peel mentioned is not available at the point of care. And if you have ever talked, now consider also that we have a care famine, and I really mean it literally, on the horizon. In the Netherlands, because physicians and nurses are being told to do more work in less time, their workload has doubled in the last 10 or 15 years. Imagine if an attorney was told to do twice as much work in the same amount of time for the same pay, and if you screw up due to missing information, somebody might die, right? If you have ever talked to a doctor or a nurse who was involved in an accidental death at the bedside, like, oh my God, what just happened? And then they discover that there was a piece of information that was missing. The Netherlands alone anticipates by 2020, 8.5 years from now, a shortage of 400,000 nurses. The only way that I can see to get through this is to give us make sure that we can get our hands on our record, disclose what we want to one doctor, what we want to another doctor, and us have control over them. And that can only be done with IT. I just don't want us paralyzed.
Thank you. We got a lot of interesting people here, plus an expert from the Netherlands.
Just wanted to add what this starts to encroach on is evidence-based medicine, which brings a whole different raft of issues. Evidence-based is, now that we have access to big data, is that we now have the possibility to say, when presented with these symptoms, the evidence says that this is the first-line treatment that you should. That's a very quick summary. It's kind of like a checklist. It says what it does, and why some doctors, and I don't want to generalize, but this is a brief time, resist it, is that it takes away their perceived, I'm an expert, I know better than the evidence. Although in all these various systems where they apply evidence, everybody says that, it's not true. So when you start using the data that way, you get pushback from certain segments of the physician clinician. And I used to be involved in aviation in another life where checklists, and the joke is, well, pilots use checklists and it saves lives, why don't doctors? Well, doctors don't go down with their planes.
Oh, that's
Woo! What a great point. Mark, everyone wants to talk.
The clinicians. No,
No,
I agree. I mean, I'm agreeing with what you're saying. In fact, in response to high tech, I wrote a piece in Health Fairs I call One Step at a Time. And I think in an academic setting like this, it's really good to ask, is this the right question? How are we doing it? But with respect to evidence, the history is that that is a word that has been overused to basically take sloppy data and coerce rational people into changing their behavior. And it's just inconsistent. That said, people throw several things in front of you when you want to stop a movement in this healthcare technology game. Return on investment, who makes money, privacy, or evidence-based medicine. They throw these kind of things at you to slow things down. That's just the game that's played. Anytime someone says that there's evidence, one has a right to inquire. And it's very clear that a lot of us are shamans when we're practicing medicine because we don't know the evidence. And even if it does, we have this ego that we're somehow exceptional when we roll the dice to be better. I built a lot of expert systems and stuff to do that. I feel comfortable grounds in saying that. On the other hand, though, when you look forward to the policy, I think you have to really ask yourself, again, what are the central questions you want to address? When are people throwing something in front of you, and when are they not? In fact, I would say, what is the evidence that anything we're doing today will lead to a better system? What is the evidence that we have? And just like Atul Gawande with the checklist, one of the problems I think people here are saying is we don't have the evidence. Just like in patient safety early days, I would go to hospitals and say, hey, do you have problems? They'd no, because if we had problems, people would tell us about it. You know, any quality movement, when it tries to improve its behavior, first and foremost, must get data, and then these data almost always make you look worse than the people that don't have data. So excuse me if I'm a publicly held company that's really doing good stuff, altruistic for profit, and you want me to get out in front and show you where I have flaws and be a target for the media. I mean, I'm not crazy. That's why I think federal, cautious, slowly, federal stuff focused on the important things, not necessarily the high visibility press things, is central to solving this problem.
Thank you. We got another question up here.
So I think you've all stated it very well, the importance of the consumer having access to this data, but at a time when millions of Americans don't have access to the internet or computers or lack the digital literacy skills to be able to access this, I'm wondering how this work at the national level is tracking with or coordinated with any efforts to achieve universal broadband access or deployment, or if it's not at all. Because if not, that's a fundamental disconnect. And I'll just kind of add, in addition to that, people with language barriers or disabilities or seniors, and how they're going to be able to achieve this or see this data on parity with others that are connected.
Devin, you want to take a shot?
Yeah, so the best that I know about that is that, you know, the federal agencies certainly talk about the need to coordinate the broadband effort that's going on with the health IT effort, both of which entail an enormous amount of taxpayer investment to spur it forward. It's a little bit harder to sort of see it on the ground. So I think the best we can say, unless somebody else has better evidence, is that the agencies are at least aware that the different programs touch on one another in really important ways, and so the rhetoric is in the right place. What that means, I think, is unknown. But the other thing that we talk about when we think about initiatives to get patients to be able to access their data in electronic form is that it doesn't, you know, a lot of people don't have broadband or computers, but most people have smartphones.
Exactly.
And an increasing number of them have smartphones, and the use of smartphones in healthcare is booming on the provider side. And so if we can
and
get
in the rest of the world too.
Yeah, and if we can get some clarity, I think there's some hesitancy on the part of some providers who think that they can't, that the mixture of mobile technology and privacy, that there isn't sort of a way forward. And so we have an obstacle to overcome there, but it's not at all insurmountable, and lots of it's based on misinformation and misunderstanding.
Dave, did you have something to add?
Yeah, except I've gone, so remind me what the original question was. Oh, yes.
Disparities and people without broadband.
Yes, I can't speak to broadband going to the most disenfranchised populations, but there are two developments in the last few months, maybe the last 6 months, that surprised me a lot on that. First of all, if you go to e-patients.net, and search for the word Emory. There's a study in process now by Emory University having to do with online PHR use by a safety net population, people who don't have a computer at home but are accessing it at libraries or at hospitals. And interestingly, this was a particularly difficult population, because not only are they economically safety net, but they're people who have at least one mental health diagnosis and a significant other comorbidity like diabetes. And amazingly, they're using the system. And it's, if they are activated patients, there's a tool called the patient activation measure. They're using it. The other was a study that was released in Baltimore in November, I think it was, where, much to everyone's amazement, patients, diabetics, severe diabetics who don't have a regular doctor, were using an app to keep track of their diabetes, their glucose and such, because that became their medical home. They could go into any clinic and pull this stuff up. Quite a surprise. And the third thing I'll mention is that I was on a panel a couple of months ago with, and I wish I could remember the name of the association, but somebody brought up the issue of minorities and disadvantaged populations. And the representative from that group there said, actually, we are no longer concerned about access because we can get at computers. What we're concerned about now is awareness among our population that the tools exist.
That's fabulous, Dave, and I particularly want to second the point that there's a lot of sort of patronizing attitudes about patients in Washington, D.C. by the decision makers. Mm-hmm. They're too unable for this reason or that reason or the other reason to be able to participate. They're not smart enough. They don't understand enough. Thank you. That's really very helpful. Okay. Yeah.
This is
sure,
along
Carl.
the lines of the low-hanging fruit kind of question that was being asked here, though.
Yes.
I saw a statistic. It was some very high percentage of the American public doesn't have EHRs at all. And so you can forget about the problem with the broadband. If they don't have an EHR to begin with, there's nothing to connect to. And so the initiatives to try to get more people into some sort of EHR where they have electronic health records seem like a linchpin to almost to many of the things one would like to do. And those things, we need to be able to move forward on them with a sufficient level of confidence about how we're doing it.
Thank you. Thank you. Cliff?
Hi, my name's Cliff. I had a question about reimagining the architecture of health records. Now, records are pretty much centrally stored and aggregated at the physician, the hospital, the insurance company. And one of the panelists mentioned, like, I don't have access to any of my health records personally. What about a system where the patient actually has physical possession of all their records? And the application would create a somewhat of a social network where the patient invites the doctor in. I go to a new doctor, and I give the doctor, my whatever it would be, my ID. The doctor comes in, and I can allow the doctor, or the doctor can grab whatever records they need. The doctor can see those records. I've got physical possession of them, and I might have 3 different doctors. Those doctors have my records. Now the insurance company needs my records. Well, the doctor can put the insurance company in touch with me and have the insurance company can get a record of whatever they need for billing purposes. But the central storage of the record is with the patient, so it's possible to track it. And the patient has that throughout their life, as opposed to they go from doctor to doctor to doctor, and then it all gets lost in the sauce, because like the gentleman down here says, the doctors don't go down with the ship, the patient does. And that wasn't really possible even a few years ago. It's possible now, although the infrastructure is not in place, but conversion to hardware and software make it possible to create a network like that. And it seems to me that if we reimagined the way we were going at the problem, not that it would be easy to institute, I understand a lot of the issues, but does anyone think that makes any sense?
Wow, this is a provocative question. Let me just say that's exactly how they do it in Germany. The patient has a key and the doctor has a key, and the doctor can't get into the record unless the patient gives permission with the key to show it. And we talk about that a lot in this country, and I know everybody here wants to talk about this. Stephanie, I don't know who's waving the most.
I can't remember whether I did this at the plenary panel yesterday or at our little group, but I've fallen in love with the robot cats that the Japanese have developed. And I want
What?
my robot cat to be cryptographically enabled and digitally signed by my doctor so that we don't have any quarrels about the records that are in there. I want to bring my little cat with me to all my appointments and blood tests and all the rest of it. So that I can record that stuff that I'm hearing orally. I'm going to have the cat do the research on the internet. Preferably, I'll have decent broadband by then, because I don't have it now.
You're not too trusting, are you, Stephanie?
No, I'm not. Old and experienced. What
Here
can I
you
say?
go.
But I think that if, having said that we need to frame this and we need to do things that make sense given the lack of a map, I think this makes sense. I also wanted to do the vacuuming. So then over to my fellow panelists.
Who's next? I know you were such Carol.
Yeah, I think this relates to some very basic architectural questions about how we can structure the system. So there's a term, a personally controlled health record. And so the idea is that nowadays the providers are legally required to give you your health record in electronic form. And so you could take that record and you could put it in a storage place of your own, and then you could carry it around with you. And so that, basing a model on patients or individual citizens having their records and carrying them from place to place themselves is one model that we have. Another kind of thought is like the German system, I believe, has centralized records, but you can use a smart card to govern control to those, and so that's a security token to give access that's limited to the system. I think it's very unlikely we're going to see a system like that in the U.S.
Too much data flow.
Well,
too many people
things.
profiting.
But another kind of option that exists out there is something like a system where providers hold the data, but then you can request transfers of the data between these providers at your behest, so that you can get data from any provider you used to go to be sent to any provider you want it to be to, or to yourself. And that seems like a practical model that I think we can do in the U.S.
Yeah, I think Cliff, actually, if your solution isn't being offered as an alternative to records being kept and shared by providers, then not only is it doable, but I think it's happening in many places.
The providers have to be able to keep the record.
They have to keep. It's a business
or
record,
a copy,
right? It's a business record,
or the original, and
So-
then you get the copy.
But if the data isn't, if the data sharing can happen with the patient bringing the data to the providers in his or her discretion, then so be it. I mean, that doesn't. These are not mutually exclusive options.
Mike?
Yeah, we actually have a PHR, so I'm going to actually jump from theory to reality. What happens is the patients can get access to certain amounts of information. The doctors are a little conservative and a little patronizing perhaps about what they can access. But there are a lot of challenges. There are things that you need to have in the record, like if I order a CAT scan on someone, I need to take ownership of that is completed. I need to track it and make sure if the patient doesn't get it done, I can follow up. I have an obligation to do that. We also have problems with language. I'll give, not to pick on psychiatry, Dr. Pio, but there's a term psychiatrists use called cyclodysthymia. How many healthcare providers know what that means?
We don't want them to know.
But it means
Neither do the patients.
The patient's kind of moody. That's what it means. But you're not going
There's
to
a
pay
reason
bill if
for
it says
that.
kind of moody. You're going to pay cyclodysthymia, though. You pay $300, no problem.
But see, we don't want to diagnose the really horrible things so they won't get a job, like depression or psychotic depression.
But it just
so we downcode.
Right, but the point is the patients are going to read that and they're going to have concerns, so we have to translate, and it's another level of effort. There's nothing wrong with that. Obviously, a patient calls and asks questions about their record, you have to explain it. But it's one of the barriers is giving patients access to medical jargon and making sure that they don't get upset. There's a famous, and maybe urban legend, of a patient that got she was depressed, she saw her doctor, and he ordered a CAT scan. In order to justify it, he wrote R/O brain tumor. R/O means rule out brain tumor. Okay, she saw the bill, she didn't know what R/O meant, and she supposedly killed herself because she thought diagnosis brain tumor, and it was enough to push her over the edge. So there's issues like that come up, and again, there's not that many. There are actually a fair number of cases of that where you have to be, when you put it into actual practice, you have to make sure that the information that's conveyed to the patient, generated by the providers, is accurate and is consumable And there are efforts in that regard, but we use a PHR now. It's very popular. Patients can log in at 11 o'clock at night, schedule their own visits, and it's just like the airlines, things like that. We share data. If they have a normal pap smear, it just goes back to them. There's a handshake saying they saw it. It's really, really popular, but there are some challenges when you put it into action.
Could a patient choose their own PHR for your
Yes,
system?
they can use, if we have the interface, there's about 400 of them out there right now. Well, maybe not quite that many, but there are a large number of them right now, and they all have to, they all will connect with the EHRs. We offer one ourselves, and we also offer bridges to others if someone already has one.
Mark?
I want to make a case that we're actually doing pretty good, all things considered, how crazy things are. And make the case that...
Are you all convinced?
Well, but make the sense, such an imperfect world, we could go on and on, about banking, childhood education, blah, blah. But the point is here that I want to assert that I don't have an absolute right to control where my information goes. Because if I have Ebola virus, and I tell a doctor I have Ebola virus and I'm infectious, and I assert my right to keep that confidential right before I hop on a plane at Reagan, I think there is a social consequence, much as if we share a river going through our property, and I don't want to get into the property versus non-property thing, but there are certain rights. Secondarily, I am privately employed by Vanderbilt University. I could say, thank God the government's not in my healthcare. You have no right to any information or fiduciary accountability. You do, because, most for-profit companies at least get tax deductions for the amount of money they spend on my healthcare. So many people in commercial firms who believe the government's not involved, it's what a lot of people call the subterranean economy, the submerged economy. We are all invested in one another. We all have accountability as citizens to one another. And the real question would be more like the way Helen Nissenbaum may say it about what are our expectations of one another in terms of how our information used. So I would never assert I have a categorical right to certain information about me because, one, I don't pay for it all and other people do, and that comes at somebody else's expense. And secondarily, there are certain areas in which what happens to me happens to you too. So there's two sides to this.
Well, now, Mark, who would assert an absolute right? Wouldn't it be enough to have the right to control information in routine situations, not in cases of, terribly infectious, potentially fatal diseases? No one would argue with biosurveillance of that, but, the right to control information in routine situations where you're awake and conscious and can be asked, it really is a different matter, don't you think?
Completely agree, and I think we need to move that way, but it's also very important for people with an extreme libertarian bent to make sure that there are certain areas in which there are social responsibilities. We agree very much.
Okay, 1 second.
I'm Guido van Noorten. I'm from the Netherlands, so I heard somebody refer to the Netherlands. And it's funny, I've been here at the discussion yesterday, and it really seems that many of the problems that you're dealing with, you're sort of doing two things at the same time. What I'm hearing most here is that actually what you need is standardization of the information in the systems, and even digitizing the systems. That's the first step. At the same time, I hear people dreaming about connecting things and maybe doing research on the data, and I think that's on the far other end of the spectrum. Now in the Netherlands, we've had about 10 years of experience with standardization, and I think we're way ahead in that terms. And the Dutch government has decided to build a platform for, sort of general access to data in the type that was threatened top before, where, you're sitting at the physician office and the physician can get basically all your data. And then only came the thinking in the Netherlands of, do we really want that? And also in terms of with the question of whether patients actually want information. A study from the UCL, University College in London, showed that people are really not that interested in their own data. It's important that the data gets to the right doctor. It's a completely different question. In the end, I think basically everyone has to be careful in jumping, instantly making use of all the possibilities. That's the main thing. And we should ensure that the reasonable cases are addressed in a controllable way without scaling up too much, because that gives a lot of risks. And that has been shown in the Netherlands. And I would like to articulate this as a point here for the audience, that it's very good to standardize. It's very good to have controlled information flows. But it's very dangerous, and I must stress that, and keep in touch after this conference. Scaling this up to a national, very large scale is really, really, really risky. That has consequences which are at many levels, not just technical, not just for intrusions, but also just controllability over one's own information. So you can easily say, I want to carry around all my information. Well, that's questionable. I think you want to compartmentalize, and certain information should stay at certain doctor places, and you need some kind of control over that. And we're starting to think about that in the Netherlands now, and I think it's good to take that into account now here as well, since you're just starting up. So that's your remarks.
Thank you. I think there was someone over here that I promised to, yeah. Let me see if I can get over there.
It's kind of an entrepreneur/creative thinker skill. Where's the invitation for people to solve these problems? Like, it seems like there are so many hurdles.
Excellent question.
It seems like as someone who would want to tackle this challenge, I don't even know where to start, because there's HIPAA, there's government, there's pharmaceuticals. Where is that path that we're trying to go?
Just today there was an email from ONC about how, what was it, Health 2.0, and someone else was, you want to talk about that, Devin?
Yeah, so actually, there was a piece of legislation that passed in Congress, and I had no idea of the significance of it at the time, but it enabled the federal government to actually put taxpayer money on the table to provide incentives for innovation, including in healthcare.
Sort of, to develop apps, contests, to develop solutions?
And apps, software, it's not just limited to apps, though, but the idea is that the Office of ONC, is the
Office of the National Coordinator.
You cannot have a healthcare discussion without an acronym or 70.
Yeah.
The Office of the National Coordinator for Health IT just recently announced an initiative. YU is the sort of person on the inside, but they've contracted with an organization called Health 2.0, which has been seeding innovation in healthcare for many, many years. And they are very soon going to release some new challenges to address some both policy and technology issues that have been confounding healthcare, some of them small, some of them large. So you should definitely keep an eye out for that. And of course, Health 2.0 has been an organization that's been around for a very long time, but it's nice to see that effort, which was really just private sector driven and kind of apart from what was going on in government with the taxpayer dollars, now being joined with the initiatives that the federal government is funding to get healthcare digital in electronic medical records of providers. It's kind of exciting. And then I think the other thing that I'll mention is what's called the Direct project. So if you want to talk about starting small and keeping it simple and solving small problems, that is actually a voluntary initiative.
Can you talk a little more about what is directly connected?
So Direct is specifying some pretty simple technology standards that will enable one doctor to share data with another doctor, like what we call in the non-technology
what's not happening, in other words.
Which is not happening. It's, transitions of care are one of the areas where people are injured, people die, and we spend a lot of money because we don't get it right because the data doesn't flow. So a simple way of taking a transaction that maybe today happens by fax, but sometimes doesn't, and enabling it to happen digitally through something that is as simple to deploy as secure email. And that's a project where they invited the innovator community to come to the table and help them figure it out, and it's ongoing. So,
Devin, is there an easy place on the HHS website anyone could find this?
Yeah, so for Direct, it's the Direct project.
So HHS and Direct
project,
would get you there.
ONC, the Direct project.
Okay.
You could also look NHIN, which is the acronym for the Nationwide Health Information Network. That's okay. That might help too.
Thank you, Dave. Yeah.
You just missed the big week. Last week was DC Health Innovation Week. There was a series of 4 days followed by a codathon on Saturday that was specifically about this. And since we're short on time, I'll just say Google Startup Health, because Thursday afternoon, Aman Bandari, who's at the top of the CMS Innovation Center, which is almost oxymoronic, except under this administration it's not. There is a big money project to do incubator stuff with incubator space and funding and mentoring. Startup Health.
Dave, I've got to ask you, is any of this innovation about patients' ability to have consent tools, segmentation, some of the things that would help them to be able to urgently protect their data from getting into the wrong hands?
The higher level answer is that in all of the speeches I heard during DC Health Innovation Week, there was not a single patient on stage speaking about what patients want.
That's typical.
And well, but thank you for having me here. That's all I can say. This is not necessarily normal. So you
all have to come to these things and speak up. You got this?
Seriously, when I started coming to these meetings, one of the first thing I realized is that the government panels are not allowed to pay citizens to just come pay for their time. And the ironic thing in health, the obvious outcome of that is that policies get written by people who are in the business. And they tend not to be consumer-centered. The double irony of that in healthcare is that the people who are most experienced at being a patient are most likely to have the most financial stress.
Before we stop, I think everyone's trying to get ready for the next speaker. Do you all want to conclude with any words of wisdom, or Stephanie?
I feel this pressure to demonstrate a cheerier vision before Deb diagnoses me with psychodystemia. But
it's really scary.
Look, reality is important, and sometimes it's depressing.
Right.
That was great.
But I do feel that all of this technological problem solving should be done within a comprehensive risk assessment, which I don't think is being done. People are solving the problems they want to solve, and one of my colleagues has assured me that we will be moving to wireless in hospitals to save money. The security threats involved in that
are unbelievable.
So a big frame risk assessment will cure my psychodystemia, I think.
Great concluding point. Thank you, Stephanie. Mark, you have
advice? Learn to be a good citizen, including, I'm going to start with me. Put it in a broader context, get educated, and try to really understand the social, economic, and technological issues.
Thank you, Dave.
One really bright star in the future, again speaking just as a data geek, an enormous problem has been for innovators that there hasn't been any readily accessible data. The best software developer in the world can't do anything.
Oh, I can tell you, the state of Texas will give you hospital data sets, large ones, for free because they're 3 years old. I'll send you the email.
Really?
Yes.
Well,
yes.
So
there's plenty of data out there, and states are selling and giving it away. I'm serious.
So two things. First of all, a year ago, the Veterans Administration provided a thing called a blue button on the website where a veteran or now a Medicare patient can click this button and download their data to their computer, and that means that there's 500,000, that there now is a common available data set that people can develop to. And also on innovation, it's kind of counter to this privacy subject, but a major reason it turns out why my data that I transferred 2 years ago was garbage was because the developers didn't have any real patient data that they could test it with.
Well, I'm telling you, come to Texas.
So now,
you don't have to come. You can order it electronically, actually.
Some patients proposed a green button saying, here, I'm going to donate my data. Take it.
Well, there's plenty sold. Michael?
Yeah, too much talk, not enough action. We're sitting here waiting for standards to emerge, et cetera. We need to put pilot programs in place and test all these constructs. We've worked out all the theoretical details. I'm getting tired of it. I've been doing it for about 14 years now. I want to see some action.
Okay.
There's considerations, privacy and safety, and there's something I nicknamed OOHIT, license to kill. And that means if you go ahead and try to operationalize based on theory, you have to do pilot testing, with proof of concept, and that's what we need to do right now.
Thank you. Devin and Carl, you got to be really fast. The next speaker's
I don't
here.
even know how to follow that. I do think there are a lot of issues to resolve, and we surfaced a bunch of them today. But at the end of the day, I think there are some important initiatives in motion that will actually enable this to happen, and there is a light at the end of the tunnel.
Thank you. Carl?
Yeah, I'd just like to call for technologists not to be discouraged by this field. So when you go into it, there are all these policy people, and they are disturbing. And
Whoa!
I do believe
and the patients?
I do believe that we can secure wireless in hospitals. I
Thank
do
you.
believe that we can do a lot of these things.
I'm glad to hear that. Well, we appreciate it. Thank you all for your patience, and we hope we see you next year.
They're just coming in for the next time.